approaches to addressing loneliness, social isolation and mental ill health. My name is Rebecca Wheeler. I'm a senior research fellow at the University of Exeter and also a co-I on one of the Pathways Plus projects. And I'm chairing today. We also have Katrine Noon in the room, who's going to be recording and tweeting. Please put, as this morning's sessions, please put any questions you have in the chat so people can try and answer them when they can. And also introduce yourself in the chat. Everyone's going to be having 10 minutes to speak. So as soon as your session's over, please unshare your slides and the next person can start sharing theirs. So without further ado, to start with then, we have Bryony Porter, Rachel Meadows from UKMSA and Dr. Chris Manning, who's a SHED leader and SHED ambassador. Talking about loneliness, mental health and wellbeing, an acceptability and feasibility study of UK men's SHED.
Hello everyone. Obviously the information wasn't updated, but unfortunately Chris and Rachel aren't able to join me here today, but you do have a lovely picture of them here on the screen. But you are lucky enough to be joined by Charlie Bethel, who is the UK Men's SHED Association Chief Officer. And UK Men's SHED Association is the charity that supports the day-to-day running of men's sheds. So thank you very much for inviting us to be here today. Charlie's going to give you an insight into what men's sheds are, and then I'm going to summarise the work that we've done, and Charlie's going to tell you a little bit more about how we've worked together and the impact of the project and the work that they do. So I'll hand over to you, Charlie.
Yep, thank you, Bryony, and hello everyone. Hope you're having a good day. So to explain a men's shed, if you put 12 men in a room and ask them to talk about their feelings, and it's a square room, 6 will leave and the other 6 will try to find the corners of that room, which being men can't quite work out that there aren't enough corners. However, if you put a lawnmower in the room and say, fix it, after 2 hours, those men will know each other intimately. They'll know each other's names, how many children they've got, how many grandchildren, how they take their tea and coffee, what ails them, and you might get a fixed lawnmower. The men's shed isn't promoted as a solution for mental health challenges or loneliness per se. It's about creating, connecting, conversing, creating things for yourself, for your community, or for your family, and doing that in a safe environment. And people often comment about being in the shed, that it's an opportunity for them to forget about their worries, forget about being lonely, forget about the loss of a loved one, forget about whatever ails them. And they're very rarely in sheds. A lot of women go to men's sheds, but we do support the men-only environment at least once a week, because that creates that safe environment. And they've been called therapy that dare not speak its name, but also more affectionately, soft play for men, which is very true. And if you can imagine men down the aisles of B&Q, well, this is like permanent B&Q for them, buying and playing with tools. So it's a very simple concept, but we've got over 800 open now in the UK. And I'm sorry, I'm not Chris or Rachel. Bryony.
We're very pleased to have you here anyway, Charlie. Thank you. So the aim of our project was working with Men's Shed Association to understand what was acceptable and feasible in terms of measuring the impact that sheds have on loneliness and wellbeing outcomes. And we also wanted to understand how people join sheds and the potential impact that social prescribing referrals could have. So to do this, we ran an online questionnaire with a series of demographic and shed-related questions using the Warwick Edinburgh Mental Wellbeing Scale and the 3-item loneliness scale that's been mentioned a lot today. We also had a follow-up questionnaire to understand attrition from the project and asked a series of questions about acceptability of sheds themselves and about the outcome measures. Then we were able to interview 21 shedders or shed members to talk to them about the acceptability of the questionnaire, but also to talk to them about the potential impact of social prescribing within sheds. We had 93 shed members who took part in our first questionnaire, and we had an 80% follow-up completion, and 21 shed members were then interviewed. The questionnaire and the outcome measures were generally viewed as acceptable to the people that took part, and we had a 90% completion response on all of the measures. Through our survey and through the interviews, we heard, and Charlie will attest to this too, that there's a unique essence to sheds that creates a space for men and for women to learn and share both skills and sometimes personal experiences in a shoulder-to-shoulder rather than face-to-face way. We also found that joining a shed was most often linked to a real significant change in personal circumstances, be that through retirement or bereavement, for example. One of the really hot topics at the moment through our projects and amongst the sheds themselves is social prescribing. And some sheds have very little experience or knowledge of working with social prescribers in their local areas. Others have quite good established relationships with their local social prescribers, where those prescribers have a good understanding of the ethos of the sheds and the dynamics and how that might work well. But we also found in our interviews that there were some very real concerns from shed members about how social prescribing may well impact the unique nature and essence to sheds and the dynamics within the sheds. And there'd been a few quite serious concerns from the shed members reporting quite negative experiences of inappropriate referrals into their spaces. One theme overarching all of the interviews was, we care, but we're not carers. Shed members do care very deeply about their sheds and their fellow members, but they are not trained care professionals, nor do they wish to take on additional responsibilities. Many of them often come to the shed for their own reasons, as a break from their own caring responsibilities at home, for example. We were able to collate a number of very practical suggestions to help people considering referring into sheds. And it was clear from our interviews that collaboration and community focus is needed to build good, strong, ongoing relationships with social prescribing in sheds. We've also been able to create 4 case study examples based on the interviews of how social prescribing may well work within sheds. And these are based on, these are sort of collated stories from across the interview, so they're not real names that we'll talk through. And I'm just going to talk through one today about a guy that we're going to call Jamie, who was a young man with autism who was not in employment or education, and he arrived at the shed after a referral from his GP. He attended his first session with his father, and he was warmly welcomed by a shed member who made a real effort to chat with him and talk to him and his dad about the different activities that he could try when he felt ready. At first, the environment was quite overwhelming for Jamie, and he sort of hid in a corner, and if it got too noisy, he had to go. But over time, and with a bit of gentle encouragement from the other shed members, he began to feel better able to take part, and he found a real niche within woodwork. Over time, his father no longer needed to come with him, and he came independently on his own every week. Eventually, Jamie stopped attending the shed because he found employment himself. And although the shed members were sad to see him go, they were really pleased to have played such an integral part in the role towards his journey of independence. As well as the case studies that we've created, we've worked with the UKMSA Association and the Health and Wellbeing Advisory Group that is part of their shed ambassador schemes to create 2 guidance documents for social prescribing within sheds. We've produced a report, and of course we'll be publishing an academic paper and writing blogs. And in March, we held an online event with shed members, social prescribers and academics from across the UK and Ireland to discuss and demystify social prescribing within sheds. Charlie's going to tell you a little bit more about the impact of our work.
Yeah, as a very small organisation, we are insight driven. We have to be insight driven, and our funders have to be insight driven as well. And to try and demonstrate the intrinsic value of sheds is a real challenge, and this has helped greatly in that to our partners. But also, it provides a great opportunity for us to know where we need to channel promotion and how to tackle social prescribing, which again is a challenge of our day that sheds want to do, but need the tools to be able to do it. Bryony.
Thank you, Charlie. So finally, I just wanted to say a huge thank you to the rest of our team, particularly to Chris and Rachel, who can't be with us today, but Chris himself, who's a shed leader of a shed in Teddington. He was the driving force behind this whole project. So it's a real shame that he can't be with us today, but full credit to him and to the rest of our team that have worked with us on this project. So thank you.
Thank you both. That was really interesting, and I love the idea of sheds as soft play for men. So on to the next one, who's Carly Wood, talking about what is the feasibility of prescribing community gardening to reduce loneliness and improve well-being in individuals with mental health problems.
Brilliant. Thank you very much, Rebecca. Hello, everyone, and thank you for coming along to listen to the talk today. It's been a really interesting morning. Yeah, so today I'm going to be talking to you just about a small, one small aspect of the work we've been doing, looking at therapeutic community gardening to reduce loneliness and improve well-being. Yeah, so just just background, we all know this information, but as we know, 1 in 6 individuals experience a common mental health problem at any time, such as anxiety or depression. And we know that common treatment approaches typically include antidepressants and psychological therapies such as cognitive behavioural therapy, but there is evidence that their effectiveness may be limited. So, for example, a recent meta-analysis identified that antidepressants may only be effective compared to placebo for individuals with severe depression. And we know that some of the issues with psychological therapies, such as cognitive behavioural therapy, are the waiting list and kind of the limited time period in which they can be accessed. So therapeutic community gardening is one type of green social prescription or nature-based activity that individuals can take part in, that has been demonstrated to provide a range of health outcomes. And this, I said therapeutic community gardening here, but this could also include all really types of gardening in your own garden, allotment gardening. There's a whole range of evidence around the benefits of doing so, including reductions in depression, anxiety and stress, improved self-esteem and mood. And also it has a range of implications for physical health due to the opportunity to take part in physical activity, for example. And in fact, a lot of this research hasn't necessarily been focused around therapeutic community gardening as a social prescription, which individuals can be referred to. And it also hasn't necessarily focused on individuals with mental ill health or a defined health need. So some of our work was about really understanding how we can increase the use of therapeutic community gardening as a green social prescription. And in doing so, understanding what are the key elements of this program of activities that really impact mental health, and what are the facilitators and barriers to referral, uptake and attendance. So in this presentation, I'll just be talking about our qualitative data, but we have a whole host of quantitative data that we're still analysing with regards to this as well. So, skipped along that. So our key aims for this aspect were to understand how community gardening impacts the mental health of attendees. And that was from the perspective of multiple stakeholders, and also to identify the barriers and facilitators to referral, uptake and continued attendance. So in undertaking this work, we worked with TrustLinks, who are an independent health and wellbeing charity in South East Essex. So they provide a number of mental health services, one of which is Growing Together, which consists of 4 therapeutic community garden sites across Essex. And they're located in Shrewsbury, Fundersley, Westcliff and Rochford, for anyone that is local to Essex and might know. So Growing Together provides holistic support to adults with various mental health diagnoses. Individuals can be referred to the gardens by GPs, social prescribing link workers, job centres, but individuals do also self-refer into the gardens. So there are a whole number of ways in which individuals come into these Growing Together projects. And when at Growing Together, attendees or members, as they are referred to at the garden sites, take part in a whole host of different activities. So general kind of garden maintenance, sowing seeds, potting, mowing the lawn. So some members choose to take on a specific job, or some members take on a different activity as and when they attend. And at the gardens, members are always also supported by mental health support staff, gardening staff and members of the public who volunteer to work with members and work on the gardens. So in undertaking this work, we use purpose sampling to include a range of stakeholders representing key personnel involved in Growing Together and members of all of the different garden sites. So we conducted semi-structured interviews with stakeholders, which included social prescribing link workers, GPs, individuals referring to the project, garden staff, garden volunteers, and also trust link staff more broadly. And we also held 4 focus groups with garden members. So the focus groups were actually conducted by peer researchers who had previously been using the gardens for their own mental health diagnosis and now volunteer on the gardens to help the other members. So they conducted the focus groups with support from a researcher. So our interviews asked questions about the barriers and facilitators to referral and uptake of the service and the kind of perceived impact on mental health, whereas the focus groups asked questions about members about their experience of attending Growing Together and how they felt it impacted their mental health. So we combined all of our transcripts for analysis and we coded and analysed them thematically whilst being guided by the research aims. So myself and another researcher coded 2 transcripts originally independently, and then we developed a coding framework to code the remaining transcripts. And these themes emerged and kind of changed as coding progressed, with the final themes being agreed between the research team. So our first kind of overarching theme from our analysis was how attending impacts on mental health. And within this, there were 3 key sub-themes. So the first key sub-theme was nature and the outdoors. So it was felt from participants, individuals referring and working on the gardens, that nature and the outdoors provided a distraction from individuals' mental ill health, and it helped actually to put life into perspective. So sometimes looking at nature and seeing a plant grow could actually help individuals to put life into perspective and see that things weren't perhaps as bad as they thought. A social prescribing link worker also said that nature is kind of sometimes can induce mindfulness, and looking at particular aspects of nature can help us to kind of live, to be more in the moment at that particular time. Another key one was social support and relationships. So individuals really felt that one of the key aspects that impacted their mental health was the ability to develop relationships, being in a positive, non-judgmental space where individuals understood what everyone was, what each other were going through. There was a sense of belonging and shared experience. And often these relationships developed at the gardens moved beyond the gates. And this was actually particularly felt for men and younger people who might be harder to reach. There was experiences of those opening up more so in the gardens. And the final theme for impact on mental health is hope for the future. So it was felt that the range of activities that individuals could get engaging in the garden, opportunities to develop skills, a sense of worth, purpose and belonging, actually encourage individuals to take opportunities and risk and think about how and where they want to go in the future. So the second area is the facilitators. What is it that facilitates referral, engagement and continued attendance? And the 2 key areas here were the holistic approach of the programme. So whilst engaging in therapeutic community gardening actually has multiple health enhancing elements, so physical activity, nature, social interaction, all of these key things, there's also the opportunity for exposure to vitamin D and sense of community. And it was felt that all of these things facilitated referral to the programme. And also members are supported with various aspects of their life, from physical health, funding, relationships. So it is really a holistic, person-centred approach which encourages people to refer to the programme and continue to attend.
2 minutes to go, Kylie.
Thank you. Flexibility and inclusivity was another key aspect. So unlike perhaps traditional kind of cognitive behavioural therapies where there's limited time frames, there is no fixed duration of attendance at these programmes. So individuals can essentially come and go as they need to and as aligned with their health needs. And individuals didn't always feel like they had to come and engage in activities. Sometimes, depending on how individuals felt on any given day, they would just come to the garden and sit and talk to people. So it is very kind of flexible and inclusive, and it enables individuals to use the programme to support their needs. And finally, the barriers to referral, engagement or continued attendance. These were largely focused on awareness and accessibility. So it was felt that there was perhaps a lack of awareness by link workers and how really to sell the service, particularly to people that might not have an interest in gardening, kind of helping individuals to understand how it could be really beneficial in terms of social interaction, helping them to make friendships. And then there's the accessibility issue, which is likely to be a key issue for individuals with mental ill health, particularly as some of the garden sites might require the use of public transport or cars, which individuals might not have. And these barriers kind of may make it much more difficult to access the service. And also, as with other types of treatment, there are potentially waiting lists for accessing these services. So finally, just to conclude, growing together, so therapeutic community gardening, just one example, has a positive impact on the mental health of attendees through engagement with nature and the outdoors, the development of social support and relationships, and the hope for the future. So all of these things combine to really, the relationships and the links with the community, all that are developed through these programs, can really help individuals to move forwards and see the kind of future and what they would like to do with it. To support referrals and to kind of increase the availability of these types of services, it's really important that community gardeners use a holistic, flexible and inclusive approach, and that we really need to raise awareness of the full range of services available and kind of help social prescribers and referrers to understand what is the best way to kind of sell the service, should we say, to individuals, like what, perhaps individuals feel that gardening might be a difficult task, but it isn't just about the garden, there's so much more to that. And I think that's really important for selling it as we go forward. So yeah, just to say thank you very much for all the support and funding for this work and to all my co-authors involved. So thank you very much.
Thanks, Collie. That was a great presentation. Moving swiftly on, we've got Luke Sheridan-Rose, and he will be talking about #kindness by post, a mixed methods investigation of an innovative participatory public health programme. Over to you, Luke. You're on mute, Luke.
Sorry, yeah, thanks. Okay, so I'm Luke Sheridan-Rose. I'm a senior research fellow in the Division of Psychiatry, and we conducted a mixed methods evaluation of kindness by post, which is an initiative that's run by the Mental Health Collective, which is a third sector non-profit organisation focused on the social determinants of mental ill health. In kindness by post, the idea is that people basically, you sign up, in practical terms, you sign up on the website and you get given a name of someone and their address, and you write them a card, and you don't put your own name on it. So you're receiving a card from somebody else in the exchange anonymously. And the idea is that it's an opportunity to do something kind for somebody else who may be experiencing a difficult time, for example. So the Mental Health Collective has been running these exchanges since 2019. They run them multiple times a year. And so far about 10,000 people have taken part. And they were particularly relevant during lockdown, for example, where it was a good way for people to sort of reach out to others. So we conducted a mixed methods evaluation funded by the UKRI Social Isolation and Mental Health Research Network. And the aims of our evaluation, I suppose the overall aim really was to conduct a sort of initial evaluation of this program or this initiative in order to lay the foundation for more substantial, more definitive research later on. So our aims with this one were to conduct an initial analysis or initial kind of measure of the impact of the intervention on people's feelings of well-being and loneliness, and to look at that impact over the period of the exchange, but also look at whether or not those feelings are sustained 3 months later. So we didn't have a comparator group, so we can't make any kind of strong conclusions about our results. But at this stage, what we've done is look to basically estimate the possible effect of any benefits from taking part in this exchange. Secondly, we had a health economics component where we looked at the running costs, so the cost per person taking part, so the Mental Health Collective, and also the feasibility and early results from a health economics component where we looked at things like health service resource use, capability measures, that kind of thing, the sort of thing economists use. Thirdly, and perhaps the biggest chunk really, was we developed a program theory for the intervention, which was a qualitative piece of work using realist interviewing. And I'll come on to the methodology in a moment. But basically, we interviewed about 20 people, and we looked to explore the key questions around who does this work for, in what context, and what's the mechanism, or why. So we collected data for aims 1 and 2 through an online survey, which we ran twice last year. So it was connected to 2 exchanges. So the main kindness by post exchange really is around Valentine's Day. So we targeted that one. We also asked people to complete the survey for the summer one as well. And we did this through email invites for everybody taking part in both of those exchanges. Secondly, for the health economics component, we also collected some information from the kindness by post executive. For the program theory component, number 3, as I mentioned, we conducted 20 one-to-one participant interviews, and we also conducted a focus group with the kindness by post executive. The aim of all of that was really to develop an initial logic model for how the intervention works, which we then fleshed out through these interviews. Just briefly in terms of timeline, early last year, we were setting up the study and all the rest of it. And then we collected data, as I mentioned, from the exchange that happened in February, and finished collecting data for that one in May. And then the summer exchange began in June. We finished collecting data for that one in October. We collected data for our qualitative interviews from May to the end of last year. And we did our quant analysis late last year. So we're actually at the stage where we've kind of finalized the results, and the manuscripts are mostly written and will hopefully soon be submitted. In total, just under 1,300 people completed at least one baseline, so took part in one of our data collections. The demographics of that group were basically about 70% of people were aged between 31 and 60, with most people being, or 25% of people being aged between 40 and 50. Overwhelmingly, the sample was female and white, and this is something that we looked to explore in our qualitative work. We kind of asked this question of why is it that this particular kindness, acts of kindness exchange is particularly attractive to white women. But what we found overall was statistically strong evidence of a small benefit to people in terms of well-being and loneliness, which was sustained at 3 months. So it has a small impact on people's lives. I think in practical terms, it's a small but noticeable impact, but probably it's not huge. In terms of the health economics, just rush through this quite briefly. We estimate that basically the cost of running this is around 60 pence at the minimum for the most popular exchanges, through to about 87 pence for the less popular exchanges. This is basically because the overhead costs are pretty much the same. So if more people take part, then it becomes cheaper per person. On top of that, we also found, again, like a small benefit in terms of capability, reflecting the sort of benefits to loneliness and well-being. And overall, we found it to be feasible to conduct a health economics piece of work. Again, that feasibility one was linked to setting out the foundation for a more definitive piece of work later on. In terms of the program theory, so the way that we approached this was we took a kind of realist approach. So the idea was the kind of key output was a logic model that described who this intervention worked for, in what context, and what the mechanism of action would be. And we did that by beginning with focus groups, as I mentioned, with the executive to sketch out an initial logic model, which was then fleshed out and refined through a series of working groups with a team, some of whom are in the meeting today, of people who had taken part in the kindness by post exchange themselves. So about 2/3 of the group had taken part in the kindness by post exchange, and some people also had experience of accessing mental health services. So we tried to really tap into the knowledge and experience, not only of our group, but also that was coming through the interviews, and to do the analysis in a sort of iterative way alongside the interviews. So we would have a working group that would help steer what we did with the next set of interviews until we had our final fleshed out model.
Just over 2 minutes to go, Luke.
Thank you. So the output basically from this piece of work was quite substantial, but I'll focus on the key messages. Overall, the main motivation that people had for taking part was to do something kind in a manageable and structured way. Given the demographics, it was often one of the key factors really that came across was people would often like to do this with their children. And it would be something that they could do maybe at the weekends with their kids. And so creating posts, they kind of reported as being a sort of positive, empowering and creative experience that itself already started to have that kind of beneficial impact. And it was something quite fun that they could engage their children with in some cases that people mentioned. But while the main motivation for taking part was to kind of create that post and to do something kind for somebody else in that sort of structured way, receiving mail actually also, people told us, helped improve their mood and well-being as well, particularly if people felt that the amount of effort that had gone into creating that post was quite sort of substantial. People really kind of appreciated the time and effort that somebody else had put into doing something kind. So overall, basically then what happens is, what we also found is that the Kindness by Post has created a sort of community of people around it, because when people sort of take part and they enjoy it and they find it beneficial, they kind of want to take part again. And so you've ended up with this sort of community of people that are kind of repeat participants. And we think that that's probably why there is a sustained impact between exchanges. So at that 3-month point, we found a sustained impact there. People basically reported that between exchanges, they continued to think about the post, what they were going to do next, and take inspiration from the social media that they'd seen around it, and also from the cards that they themselves had received. Just conscious of time, I'm going to move on. Just to say a quick thank you to everybody who was involved, including Bev, who we heard from earlier, and who's on the call, but this is the project team. Okay, thank you.
Thank you, Luke. It's really interesting. Last but certainly not least, we have Margaux Liebmann talking about, do people perceive benefits in the use of social prescribing to address loneliness and or social isolation? A qualitative meta-synthesis of the literature. Over to you.
Thank you very much. Thank you. I hope you guys are okay. So what I'm about to present is research that I completed as a part of my master at UCL. So it aimed to investigate the perceived benefits of social prescribing to address loneliness and social isolation. So like I just said, to address loneliness and social isolation, we looked at social prescribing intervention. But what is that? Well, social prescribing is an approach which refers people with psychological, social, and practical needs to non-clinical services and activity within their local community. So for these interventions to work, 3 people are needed. First, the prescriber, who is often a healthcare worker, such as a GP, a service user, who is feeling lonely or socially isolated, and a link worker, who will refer the person to the community-based support. Among these supports, there are art-based activities, walking clubs, communal gardening, museum visits, exercise classes, and so on. So at the moment, there are gaps in the literature about which interventions are the most effective and accepted by service users to reduce or prevent loneliness. Furthermore, current evidence is mixed with contradictory findings between quantitative and qualitative studies. There is also a lack of research focusing on young and midlife adults, which highlights the common perception that this experience is confined to older people. So there were 2 aims to our review. So first, we wanted to investigate the acceptability and perceived effectiveness of social prescribing on loneliness and social isolation from the perspective of the participants. Second, we wanted to investigate the potential mechanism by which this might occur. So to do so, we conducted a qualitative metasynthesis, which is a systematic approach to search, screen, extract, and code qualitative data. Several databases were searched to find both published and unpublished articles. So studies were included if people of any age described experiences of loneliness and social isolation, if any well-defined social prescribing intervention was used, if there were reports of service users' views about the use of social prescribing to address the loneliness, if the articles analyzed data from focus group, interviews, textual data, and if they were written in English or French. So as you can see it on the flow chart, the initial search yielded 1,789 publications, and we included 19 articles in our review. To answer our research questions, we used a thematic analysis to identify common themes across the included studies. Then to assess the quality of the included studies, we use a critical appraisal skills program checklist for the published studies and the AACODS checklist for the unpublished ones. A second independent reviewer checked 20% of the quality appraisal, and all included studies were judged to be of appropriate quality. So after analyzing the data, 3 main themes emerge. So I have selected quotes for each one of them so that you can have an illustration for them. So the first theme, increased sense of well-being, is divided into 5 sub-themes. So let's dive into it. So to express a reduced feeling of loneliness and social isolation, one participant said, for example, "It made me feel less lonely, and coming out into places where there are quite a few other people is what makes a place like a museum feel more familiar, and that can't be a bad thing." Second one, the sense of belonging to a community is illustrated by this quote. So there is a sense of belonging in this room because we are all in here together working. That sense of belonging carries out because people get up, talk, encourage each other. It's a very nice feeling here. One participant reported feelings of improved self-confidence and self-worth by saying, for instance, "Well, because I've been going further afield with the link worker, I feel more empowered to do better things and improve my life. I've got more confidence to do things." For our 4 sub-themes, the sense of purpose, pride, and achievement also came up several times in the studies. As one person reported, "I'm doing something different. I'm achieving something in my old age I didn't think I'd be able to do." And finally, our last sub-theme, distraction, was experienced by a few participants only. For instance, one said, "When I have social things to do, it helps with the other stuff. Sometimes when you're just so focused on your issue, you don't have time to recuperate. And this break just gives you an opportunity to let go and unwind. It's just good overall to escape for a minute and kind of give you clarity of what's going on. It's a welcome break." So the second theme, factors that engendered an ongoing desire to connect with people, relate to the realization that newly formed relationships were valuable. Here are some examples. It's like you feel when you're going to meet a friend. Coming here is enjoyable and I look forward to it. And it was interesting to meet other people in similar situations to me, to hear about their experiences and what they've been through, how they were dealing with things. Finally, the last theme, drawbacks perceived in social prescribing, capture what had apparently prevent participants from gaining the benefits we've just described. So for example, one said, "Maybe I just didn't really feel like I fitted it in. I didn't really like the people I was around, and they were not my age, and that was not people I really have a social life with. Or I just didn't like the atmosphere at all. I think the staff were very impatient, and I think with very elderly people, you've got to be really patient." This is it for our results. So our findings have several implications for practice and future research. So to address the perceived drawbacks that were reported, we believe that social prescribing interventions should be better tailored to individuals' needs and interests. To do so, link workers could assess participants' interests to gather them in the same groups, and then conduct one-to-one sessions to evaluate whether the expectancies are met or whether they manage to create meaningful relationships, for instance. From a public health perspective, it is important that social prescribing is provided equitably between all ethnic groups, age groups, and socioeconomic groups, and therefore distributed by local authorities, community organizations, and charities, in addition to GPs. Since our findings mainly included samples of older females in Western settings, we believe that further investigation into the experiences of specific sociodemographic groups is also required. Furthermore, doing more qualitative work to obtain link workers and family caregivers' perspectives of which strategies have the most benefits might also be useful. More research could also be conducted on the underlying cognitive and social mechanisms that cause social prescribing to be perceived as beneficial. We also suggest isolating the impacts of link workers from the impacts of the community activities to understand their relative contribution. And well, since previous research is quite mixed, there is a need for high quality trials, such as RCTs, to determine their effectiveness in reducing loneliness and social isolation. So to conclude, let's go back to our two aims of the review. So for the first one, we found that individuals experience not only a perception of reduced loneliness and social isolation, but also a sense of increased well-being. Findings also suggest that participants were more confident to interact with others when they shared similar interests and had common experiences, and that social prescribing provided opportunities to expand one's social networks. Nevertheless, we also identify some drawbacks that prevented service users from gaining these benefits, such as not sharing interests with others, dealing with important health issues, and not liking the link workers. Regarding our second aim, our findings...
Margaux.
Okay, thanks. Our findings suggest how important the link worker is, whose role is to model the creation of a relationship based on trust and empathy, where the service user and the link worker co-design a solution and interact on equal footing. So I also believe it's worth emphasizing that one-size-fits-all approach is very unlikely to be appropriate, as the success of the intervention depends not only on the available local resources, but also on the needs and circumstances of the service users. Therefore, this suggests a need for more person-centered social prescribing in choosing from a wide range of social prescribing intervention. A flexible two-step approach combining an individual interaction with the link worker and then with other service users in a group setting, depending on the needs and aspiration of each service user, could therefore be the ideal model. Thank you very much for listening, and a huge thanks to my supervisor who have supported me and guided me with this project. Thank you.
Thank you, Margaux, and thank you all of you for doing excellent timekeeping, which has made my life much easier and means we've got just over 15 minutes for discussion.